this video, we will be showing the nuances of ILM peeling in difficult situations. Here is a case of proliferative diabetic retinopathy, and you can see the shining taut hyaloid and under which there is a lot of bleed. We are just removing the hyaloid here, and once we remove the hyaloid right from the disc and move it on, you can remove the blood. We trim the hyaloid here and reach the retina to remove the pre-retinal blood. Once the pre-retinal blood is gone and once the ILM is now clearly visible, there is a stain there already which is there because I had used brilliant blue-green at that point of time. You can see that there was a vitreoscheisis. So immediately after the stain is done, you are taking further hyaloid. That is basically because there is already a vitreoscheisis in place. So this is a very important thing in proliferative diabetic retinopathy, where vitreous may be in two layers. And now you are having the actual ILM peeling. This is a case in which there is a traction retinal detachment with secondary rhegmatogenous retinal detachment, and you can see that there is a detached retina. In detached retina, either you can use a PFCL to flatten the retina and then do an ILM peeling, or you can shear and induce a small tear in the ILM somewhere and then take it on in presence of retinal detachment. In this particular case, what I did was I did a fluid-fluid exchange to flatten the retina maximally. Could see that when I was removing the ILM from the temporal side towards the disc, there was no fulcrum against which I could put pressure, and it was extremely difficult. Whereas when we are able to remove the ILM from the disc towards the temporal side, it will be much easier to come in a detached retina. So in this particular case, we have completed the internal limiting membrane peeling from the disc towards the temporal side, as you are seeing now. Once we finish that, then we can complete with the air fluid exchange, a laser and silicone oil injection. In this case, there is an epiretinal membrane which is very tough on the central part of the macula. So we are removing the membrane, and always in an epiretinal membrane, after removing the membrane, there may be some ILM which went along with the epiretinal membrane. So after we remove the epiretinal membrane, we should always try to stain the ILM and see how much area is left behind. So this is the ERM peeling. Now I am staining the ILM with brilliant blue-green, and you can see that already there is a lot of area which has been peeled. In taut posterior hyaloid, here you can see the central part of the epiretinal membrane not taking up the brilliant blue stain. It's called negative staining. You can start peeling the ILM from a part where you can think that there is a cleavage. If you are seeing a cleavage, start peeling from that particular area. Always look for a cleavage or an area where there is a separation, and probably a preoperative OCT can also help us in that regard. So when you are close to the central fovea to take the ILM, there may be vessels which can get damaged. So generally try to grip the ILM away from the blood vessels. Here in this case, I am trying to make a flap and insert that flap into the hole, but you can see here that I lost the flap. So we can take the nasal ILM and then you can use it as a flap later. In this case, even though I am carefully trying to put that ILM onto the whole area, I will be losing that. So once you lose that, don't lose hope. You still have the nasal ILM to put into the hole so that an ILM flap can be created. In this particular case, after the ILM is removed, so because the hyaloid is on top of the ILM, I can very easily lift up that, because that gave me a guidance to where the hyaloid was. So you can see all around, I have now removed the hyaloid, the taut hyaloid completely, and then complete the vitrectomy. And after this is over, we can take the nasal ILM and stuff it there. So you can see here that I have again stained with the brilliant blue-green, and that is the nasal ILM which I am talking about, which can be used as a flap. So once we finish the flap, you can remove the remaining internal limiting membrane and complete the surgery with a air fluid exchange. In cases where you are holding the ILM very close to the fovea, there is always a risk of bleed occurring because major vessels or larger vessels will be there, and inadvertently if you touch there can be a bleed which can occur, like in this particular case. This is very close to the fovea, and sometimes in patients who are on antiplatelets or anticoagulants, post-operatively also these bleeds may create troubles because you cannot do anything to reduce the bleed from there. It's very close to the fovea. At this point of time, probably we can raise the bottle or increase the pressure so that it can be done. This is a case in which you can control the ILM. You make a small opening, and then nasal ILM is much easier to remove and will come as a curvilinear fashion. But temporal ILM is more difficult. This is the nasal ILM. Temporal ILM, it is more difficult to be removed because our leverage with our hands are also a little poorer. Probably you can use the other hand for removing the technique if you are ambidextrous. Plus surgery can have problems as well. This was a sharp needle which was used to inject brilliant blue, and that sharp needle touched the macula to a bleed. So after this particular incident, I have moved to a silicone tip back flush for injecting the brilliant blue-green dye. You should also make sure that the injector and the needle are very, very tightly opposed. Sometimes the needle can be pushed and it can go and hit the retina as well. In this case, whenever there is a trauma onto the retina, an ILM peeling from that particular area is also a little skeptical because you may injure the vessel further and cause further bleeding. In this case, it was not to be.